To control severe internal bleeding or deliver targeted radiation, interventional radiologists rely on a single continuous highway, the human vascular tree. Within the abdomen, the blood vessels feeding the liver and the spleen represent high-stakes environments where a single miscalculation causes massive tissue death. This simplified model reveals the liver's structural advantage, a dual blood supply. It connects to a massive venous conduit and a smaller arterial conduit. The portal vein delivers the vast majority of blood volume and nutrients, while the hepatic artery supplies the highly oxygenated flow. Because the liver pulls from two independent sources, it possesses a built-in redundancy. The spleen does not have this backup system. Without a dual supply, the spleen acts as an end organ. Its survival depends entirely on a single arterial inflow. Recognizing this exact divergence in fluid dynamics dictates how a physician navigates the vessels to stop traumatic hemorrhage or deliver toxic payloads to a tumor. Treating a highly redundant liver artery the same way as a fragile splenic artery guarantees severe organ infarction. The architectural rules determine the medical protocol. Following major blunt trauma, a patient can develop a continuous active hemorrhage inside the liver, often forming a pseudoaneurysm. A pseudoaneurysm is a contained pool of turbulent arterial blood pushing against weakened surrounding tissue. A physician cannot simply block the entire main hepatic artery to stop the bleeding. Massive, non-selective embolization starves too much tissue of oxygen, leading to large volume necrosis and the formation of a life-threatening hepatic abscess. The treatment must be targeted, but there is a strict mechanical rule. Metallic microcoils must never be placed directly inside the pseudoaneurysm sac itself. Packing the sac directly does not stop the arterial pressure feeding it. Blood continues to pound against the embolic material, causing the weakened sac wall to expand and eventually suffer a catastrophic late-stage rupture. This diagram illustrates the definitive solution, the sandwich technique. Here is a branching artery with a balloon-like pseudoaneurysm, showing arterial flow swirling inside. First, the physician navigates the catheter past the injury to deploy the coils, physically blocking the distal outflow vessel. Next, they withdraw the catheter to a position just ahead of the injury and block the proximal inflow vessel, perfectly trapping the pseudoaneurysm between two mechanical walls. This isolated arterial segment is shut down, but the surrounding liver tissue survives. The liver's lack of true end arteries means an extensive collateral network, along with the portal vein, easily compensates for the blocked passage. Before removing the catheter, the operator performs a completion angiography. Angiography is an imaging technique that uses contrast dye to definitively prove all flow to an isolated segment has ceased. The liver's redundant flow pathways allow the sandwich technique to safely eliminate the bleeding site without risking widespread ischemic damage. If that same blunt trauma occurs in the spleen, the lack of a dual blood supply forces a completely different strategy. The spleen's deep, distal arteries do not have neighboring collateral vessels waiting to take over if the main supply is physically blocked. Deploying coils deeply into multiple distal branches within the spleen starves the tissue permanently, resulting in complete, irreversible infarction of the organ. When faced with multiple bleeding sites in the spleen, the correct approach is a proximal embolization strategy. This diagram displays the main splenic artery trunk, along with smaller bypass vessels known as the short gastric arteries. The physician places a mechanical plug into the main splenic artery, deliberately positioning it upstream, or proximal, to where the short gastric arteries connect. This manipulates the fluid dynamics perfectly. The short gastric arteries maintain enough trickling blood flow to keep the spleen alive, but the overall perfusion pressure drops. The slowed blood naturally clots at the bleeding sites. By reducing the pressure rather than eliminating the flow, a large portion of the spleen remains highly functional. This preserves the patient's immune system, typically sparing them from needing post-embolization vaccinations. This mechanical manipulation of blood flow applies beyond physical trauma. It is also the primary mechanism for treating malignant tumors like hepatocellular carcinoma, or HCC. HCC is a primary malignancy of the liver that originates in the hepatocytes. As an HCC tumor grows, it develops a specific microvascular anomaly. It aggressively parasitizes the local arterial network to fuel its rapid expansion. This cross-section shows the localized tumor mass rapidly pulling its blood almost entirely from the arterial inflow, while the surrounding healthy liver tissue continues to draw primarily from the venous inflow. Interventionalists exploit this difference using transarterial chemoembolization, or TACE. TACE is a localized procedure that delivers chemotherapy directly to a tumor while physically blocking its blood supply. A high concentration of chemotherapy is bound to an iodized oil called lipiodol and injected into the hepatic artery. Because of the tumor's intense arterial greed, it preferentially siphons the heavy, toxic oil directly into its own cellular bed. Immediately following the oil, the physician deploys tiny physical particles into the artery. This blocks the outflow, slowing down the washout and trapping the toxic payload inside the tumor for a prolonged period. This aggressive, localized attack relies on the health of the remaining liver. Therefore, decompensated liver failure, where the organ is already failing to perform its baseline functions, is an absolute contraindication for TACE. Similarly, if a patient has portal vein thrombosis, a blockage of the primary venous supply, performing TACE becomes highly dangerous. Shutting down the arterial supply when the venous backup is already offline guarantees total liver infarction. The injection site must also be strictly controlled. If the embolic agent is mistakenly injected before the takeoff of the cystic artery, the toxic oil flows directly into the gallbladder, causing severe sterile or chemical cholecystitis. TACE succeeds purely by manipulating flow dynamics. It weaponizes the tumor's aggressive arterial biology to deliver a fatal dose, while the venous-dependent healthy liver remains safely fed by the portal vein. For patients with highly advanced tumor burdens, physicians can replace the chemotherapy with a radioactive alternative known as yttrium-90 or Y90 radioembolization. Y90 is a high-energy beta emitter loaded into microscopic beads. Once injected, it delivers 94% of its radiation over a highly concentrated 11-day window. Each microscopic bead emits an expanding radiation field that stops completely at a maximum range of 1.1 centimeters. Because these beads emit high-energy radiation, preventing uncontrolled movement through the bloodstream is critical. Physicians must first calculate the lung shunt fraction. During a pre-procedure mapping run, a tracer is injected to determine exactly how much fluid naturally bypasses the liver's capillary beds and escapes directly into the pulmonary system. This establishes a hard safety limit. If the calculated shunt fraction would deliver greater than 30 Gray to the lungs, Y90 therapy is strictly contraindicated. Gray is the standard international unit used to measure absorbed doses of ionizing radiation. This diagram shows the second major constraint, preventing catastrophic non-target irradiation of the gastrointestinal tract. The proper hepatic artery is shown here splitting, with the right gastric and gastroduodenal branches curving away toward the stomach and intestines. The anatomical takeoff point of the right gastric artery is highly variable from patient to patient, making it a prime risk for accidental reflux of the Y90 payload. To prevent this, the physician performs a prophylactic coil embolization. They intentionally block the right gastric and gastroduodenal branches before the Y90 is introduced, physically walling off the route to the stomach. The intense localized radiation of Y90 requires absolute spatial control. The procedure depends on mapping every flow pattern and plugging every collateral escape route before the isotope ever leaves the catheter. Stepping back, the intricate abdominal vascular network reveals a strictly ordered system of pressures and fluid dynamics. Treating the liver and spleen are never isolated acts of arbitrarily deploying coils or injecting radiation. The interventional radiologist actively manipulates fluid pressures. They exploit the specific arterial dependencies of tumors and respect the mechanical limits of collateral flow. The physical architecture of the human body dictates strict rules of engagement. It violently punishes blind guesswork, but rewards precise structural logic. By leveraging the liver's dual supply resilience and actively mitigating the spleen's single-vessel fragility, interventional radiology transforms chaotic internal bleeding and aggressive cancers into controlled, localized cures.